Welcome to Quality. This is your host, Arjun Venkatesh. Today's episode is the next in our substance use disorder series, and it's a critical piece of thinking about how we extend our work helping treat opioid use disorder to pediatric populations. I'm excited because we've got two great guests today. I have Dr. Alex Nager, who's the Director of Emergency and Transport Medicine at Children's Hospital LA, and Dr. Rebecca Ba'Gah, who's a pediatrician and pediatric psychiatrist at Chalk Children's in Orange County, both of whom have been very active with the California Bridge program. And that's actually where we're going to kick today's episode off. So, welcome both. Thanks for joining.
Thanks for having me.
Thank you for having me as well.
Yeah, it's great. So when I think of the California Bridge program, and we've had several folks from the program on our prior episodes of our podcast, I often think about, public hospitals in California, often adult emergency departments, and this sort of special support that exists in California to make sure that not only people can get treated for OUD and the ED, but often ED-based programs that are bringing back, adults again to sort of get subsequent treatment. I don't think I've ever thought about it in the pediatric population, but it sounds like you have both not only been partners with California Bridge, but have really figured out how to extend it to that pediatric world and get it up and going. And so tell me about how you got hooked into this.
Sure, I can go ahead because I believe we were the actual first children's hospital to be involved in this program. And we fortunately have a very robust psychology department that's always looking for new opportunities for our hospital. And they found this opportunity in this grant and applied for it, and we received it. And like you had mentioned, it was a very different world because work has been primarily done with adults, and we were sort of opening up a new door. And I have to tell you, it required an entire village because at the time that we received our grant, we did not even have buprenorphine in our hospital. Prior to that, this was at the time when the X license was leaving. And so I actually came to Chalk in 2021 and was the first person in the hospital to have an X license. Didn't really need it at that time. And what I mean by an X license, sorry, is at the time, probably everybody knows, but just in case, in order to prescribe this medication, buprenorphine, which is indicated for treatment of opioid use disorder, you needed to have a certain certification in order to do it. And in the pediatric world, this was not common practice. And so being that I had psychiatry background, that's how it came to pass that I knew all about this. And so it really was truly from the ground up, where it was meeting with getting everybody in the ED, first of all, involved and having them partner with us with education. A lot of this was our first sort of 6 months into the program was just all about education. What is this? Why do children need it? And then, like I said, partnering with the pharmacy even to go through all of their policies and procedures to even get this on formulary so we had it available. And then partnering with the community, because I think that's what was so great about the bridge was it gave us information to how do we help these children basically start them on these life-saving medications instead of like while they're presenting and then linking them to service afterwards. Because I think that was another challenge. I think when we first started, there was one physician in Orange County that would see patients who were on Medicaid. And so trying to build these connections and then work with the county to get more resources for the children. So it was like a multi-level approach. But fortunately, people realized this was a problem, that there was a very, I won't say easy, but honestly, quite easy solution to it. And then getting all their buy-in to help us sort of kind of net everybody, if you will.
That's great. And I know it's no easy work sort of pulling all those people together, but once you can sort of, and we've seen this, from many success stories on the podcast, once people get a few of the dominoes to fall, then the rest start falling, because it's work that people want to do and they sort of want to make sure that they are helping this remarkably vulnerable population. Alan, what was your experience?
Well, our experience was not unlike that experience that Dr. Ba'Gah just mentioned. The motto I had that carried through the initiative was, let's save lives. Because people wanted to say, oh, this is an adult problem. Those medications are dangerous in kids. So I started out small. I started out with a small group of very interested, passionate people. We developed a protocol. We met with pharmacists. We called and affiliated with outside addiction experts. A group of us had to get our own education up to speed. So I took a number of courses and we chipped away. We developed a protocol. And since I'm the director of an emergency department, I had already seen the tragic and large number of adolescents coming in with opioid withdrawal and said, this needs to be my personal mission to do something about it and help address this epidemic that's hitting all of us so very hard. And so it was really, really taking small, realistic steps. And eventually, over about 3 to 4 months, we got all the pieces in place and we started our program, which has been highly successful. In fact, we just submitted our publication describing our program. We're speaking at a national conference in about 2 weeks. And so we're getting some traction, and that's a great thing.
No, that's wonderful. And there's something as I'm talking about that hits me, which is there's something sort of almost visceral when we talk about an adolescent with an overdose and this idea of saving a life. And it's because it's a child. And I don't know if you've been watching the TV show The Pit, but in one of the early episodes, there actually is an adolescent with an overdose death. And I can imagine that can be a very powerful motivator to bring people together. On the other hand, we live in a world right now where there's tremendous fiscal pressures on hospitals, particularly when you're taking care of children with all the pressure in the Medicaid program. And I've tried to start a lot of programs over my days, and there's at some point always sort of this conversation about budgets and ROI and all that other stuff. And so was that a barrier for you all, or is this something that it really just required some will and not necessarily a lot of dollars to make happen?
I think for us, fortunately, we have already a system in place in our emergency department where it's called a mental health emergency services, where it's a team that helps to do the evaluations on children that come in with a mental health issue. And so fortunately, we had those people in place, but the difference was they were used to seeing kids coming in who had been positive on a suicide screen, not necessarily somebody who had come in with an overdose or had a substance use disorder or issues. And so fortunately, we had the people there, but it was communicating that they're not only there now just to help with the suicide, but also with the substance use. Because I think that's, a tricky thing with children is a lot of times when a child comes in with an overdose, not a, non-fatal overdose, sorry, is there's people want to admit them. And I think that's always been the difficulty is, because they want to make sure that these kids are well cocooned, and that they have all the services. And so that's what's been so wonderful about this bridge program is that something that doesn't necessarily need an inpatient stay, but does need the support and the linkage. This was now creating that, because I think that was always the question is, what do you do with kids? Again, because substance use disorders technically don't go to an inpatient psychiatric unit, although a lot of them do have psychiatric issues. And so we have admitted some of them to our psychiatric unit, but some of them that are purely there for substance use disorder, it was always like, ooh, do they go to the medical floor? What do they do? But now that this bridge program exists, where we have people in the emergency department, part of the program is something called a substance use navigator. And it allowed for one of those people in our mental health emergency services, who are usually licensed clinical social workers or marriage and family therapists, to be able to have the knowledge and the skill set through special training to understand the disorder, what the children need, and then help the families, link them to services as well. So I think, and then, sorry, another thing with that is there's a way for that person when they're doing the service to be, I apologize, I'm forgetting the name, and maybe you know this, doctor, but it's like a community worker. And so they were actually able to bill for the service as well. And so that helped to get the buy-in, I think, from the hospital as well. Because you're right, unfortunately, money does count.
That's interesting. You found a way that it was even billable, because I think is, something that we've heard from a variety of providers over time, that, if there's a way to sort of make this fit within our existing business models and make people see it as a service that we do, just like we do other services, from the hospital, then that's something that's really facilitated their adoption. Alan, are you all sort of built on a similar substance use navigator type model? And billing for it as well?
Well, it's part of our billable emergency department services. So yes, everything is billable. We did have a navigator that was funded through the California Bridge Grant. So that navigator existed for about a year. Unfortunately, then that position faded out. But we developed algorithms, protocols, process maps. I also make myself on call 24/7 for any opioid withdrawal, so that when one of my physicians is managing a patient, they literally call me 24/7 so I can verify that they're walking through the process accurately and effectively. So we don't have that navigator, but I think the system is now relatively entrenched that we've maintained sound effectiveness.
Yeah, we've actually, one of the things we've observed in the Equal network is we have about 500 EDs around the country that are participating in the network and doing this. And the common question or the common lament often is, well, we're not in California. We don't have the bridge program, or we didn't get support for a navigator. And one of the points I've always made is, but look at the performance of many places that don't have the benefit of that across the rest of the country. And I think the point you make is a big one, which is there's sort of two hurdles that you have to get over. Hurdle one is this sort of initial getting people comfortable with, and it's harder and people aren't sure what to do. And so there's a real value of that navigator in terms of, and like you use the word entrench, processes, mindsets, perspectives. But then you still have to figure out after the fact, what are you going to do about the fact that people still like to have their hand held through the process? My guess is for your average clinician, you know, they're only writing a buprenorphine prescription, what, once every month at most, maybe even some people are doing this once or twice a year. It's hard to do that, right? That this is a low frequency event, and so it's really hard to help support people on that. And so I'm interested to hear how you've approached that versus the things that people take care of asthma every day, right? So it's very different about when we think about changing asthma care than something like this.
For us, I believe it's over communicating, right? And I think that's where, a lot of people know, just like other doctors saying, we're the go-to people, but obviously, I also have other team of, it's really psychiatry in our hospital that's helpful because again, I know that there's a lot of push and we've been doing a lot of education with our pediatricians in the community and in the hospital to get people comfortable, right? Because again, unfortunately, a lot of people think of this back to that as an adult issue, but I know it's now a lot of the, not, I wouldn't say full expectation, but at least we're trying to make it that all of our trainees understand how to start buprenorphine. And we have a huge network of community pediatricians down here in Orange County. And so have met with all of them, making them aware that this even exists and that we can do it. And then I think at the beginning, you really have to have people that can hold the hand. I mean, the thing that's so wonderful about, again, the bridge, and I know not everybody has this, but it does have a whole network of phone numbers available if you didn't have somebody like us who was available to call and say, oh, I have this kid, what do I do? Because I think it's not that people don't want to help, right? I think it gets misguided that it's like, no, we don't want to help these children, but it's more of coming from a fear of I don't know what to do just because of not having this experience. And so I think we have just tried to make sure that our consult liaison psychiatrist, myself, even our director of psychiatry, we're all there in case anybody has an issue that they can always call us. So I think that's I'll say it's a luxury because I know not every community hospital has an embedded team of pediatric psychiatry to help them, or addiction medicine specialists, or a person that's championed this. But I think trying to find somebody and have that sort of be the rock and the root, and then from that everything can grow. Because you're right, I mean, it's not something that we're doing daily, right? This isn't, like you had mentioned sepsis earlier, this isn't something that we're like, this is our bread and butter, but so necessary because it's so easy to do with such a huge impact of saving lives.
Yeah, the idea of being able to call, I'm sure that resonates with Alan. When I think of often when we have a big pediatric transport team, and the importance of often having teams like that is that you have children receiving care in a variety of facilities where if it's bread and butter stuff people do, they're comfortable with it. But the second it gets a little uncomfortable, the ability to pick up the phone and call a friend is just invaluable. And my guess is that sort of parallels the world in this space as well. Anytime you do QI, one of the things we teach on the Equal Network is big, hard problems don't fix easily, and they usually don't fix the first time you try. And so tell me about something that surprised you both as you got this up and going, either positive or negative, that you didn't see coming, but you think that is something that our QI directors or other listeners who are leading similar projects at other Equal EDs should be ready for.
I think one of the things that surprised me, and I think we both alluded to it early on, is the resistance to do something that mattered. So just getting buprenorphine available took weeks of convincing pharmacists that this was something that should be put on our formulary and be readily available. I brought in 2 or 3 addiction experts. I brought in a pharmacist who deals with this. We developed an algorithm, a protocol, a guideline specifically outlining the pharmacology and pharmacokinetics of the medication. I spent the time to bring in speakers to educate my 40 pediatric emergency medicine attendings so they would feel comfortable with not only the protocol, but the drugs used to treat withdrawal symptoms. Yet, even with all of that, there was still pushback until at one point there seemed to be an aha moment where it just all fell into place. We got the approval. One of our ED pharmacists called me and said, Alan, it's available. And that was a bright day in my career.
That's good.
That's amazing. I mean, I think what was the most surprising thing for me is, I did my training in Kentucky, where you think just, less resources, right, than Southern California. However, like I had mentioned earlier, we see a lot of children with Medicaid. That's a majority, I would say, of the patients that we see. And the fact that in Orange County, where you think this is a resource-rich area, there was one provider that would do outpatient buprenorphine. I mean, at one point, I am an inpatient doctor, and I was doing a makeshift clinic because there was nobody to see these children. And it was like, because again, the hard part for us who understand this is a matter of life and death, right? And there's an easy solution, right? It's a lot harder for me to deal with a suicidal kid than it is for a kid to just do buprenorphine who wants to quit, right? And so I think that to me was the most surprising thing, because, all of this was getting started, in the early 2020s, this was all in the wake of all the opiate stuff in the news and the big settlements. And so I think where communities were doing a lot of work, it was still in the adult world. So I think everybody thought, oh, tick, we have these, clinics. And I got a list of clinics, and it was methadone clinics for 18 and older. And I was like, that isn't helping my kids. And so I think that was the most surprising thing to me. And I will say that I am glad that the county has responded, and now there are more services available for these children. But it still feels like there is some gatekeeping going on, and that makes it a little bit difficult, because it's I think when you're on the ground, you feel a little desperate, because you're like, these children, the good thing is they come back after an overdose, right? The scary thing is they don't make it back. And so the fact that when you're trying to get them into these programs or get them the help, and sometimes it's like you have to go through these very strict A, B, C, D, E to get it, that part can be a little frustrating. But I think the both of us have shown that by not giving up, and I'll say being relentless, because it sounds like you were relentless over there up in LA, but it worked. You can get it done.
Let's talk about this follow-up thing for a second, because I will say it is the single biggest issue brought up when we do qualitative work with community EDs around the country, around, what's got you stuck? Why didn't you start a program? Or what happened to your program? And the quick thing said, well, we didn't have like easy follow-up, or follow-up was difficult. And so sometimes that actually results in people sort of, throwing up their hands and giving up on doing this. And I always feel that that is just more a reflection of the fact that, it's hard to deliver good healthcare today. Access is a problem for anything. Like when I have a diabetic patient, it's not like I can get them in to see endocrinology, or our neurology follow-up wait times are something like 3 months. Even if somebody's had a TIA or a stroke, it's almost impossible to get a follow-up. And so to me, that doesn't feel like a substance use disorder issue as much of a, yes, American healthcare is broken kind of issue. And how do you, what do you tell those folks though? When you sort of want to say, hey, let's do this, we're doing something new, we could save lives, you want to treat. And the answer quickly is, oh, but follow-up's impossible, it's so hard. Why even start if we can't get somebody follow-up?
Well, let me address the follow-up, because you hit on something that we were very concerned about, which is we can treat them in the emergency department, but then where do we send them? As you can imagine, most of the MAT programs treat adults. And so trying to find a number of programs willing to see adolescents was challenging. We did, in the whole LA County region, find 5 MAT programs willing to see our patients in follow-up. But with that, and we track this, 100% were referred to a MAT program, many through that navigator when that position existed. And it turns out 50% showed up at their first MAT appointment, and only 42% showed up at 30 days. So that's a big problem, because clearly that's a large drop off. But the momentum was created, and our hospital, through the Division of Adolescent and Young Adult Medicine, as of a month and a half ago, we now have our own in-house MAT program that's fully staffed, resourced. And so now we have the ability to refer our patients to our own MAT program, as opposed to many in faraway places for many of our patients. You know, LA is a place where if you have to drive 25, 30 miles to get to additional follow-up treatment, that can be dissuasive.
I was going to say 2 or 3 miles can sometimes be a challenge.
Yeah.
Forget 20 or 30. Yeah.
That's wonderful. Congratulations on that, because I think for me, coming from mental health, where we're constantly trying to change systems, because I think that has been the bane of our existence, is connecting children to care. And so I think for us, it's sort of in our blood to realize that there's problems. And I'm so glad that it's not just me, because this takes a village, like I said from the beginning, but I have quite a robust team of different, from psychologists to social workers, to physicians, that really work with the community. And it's already using those existing relationships to just be the bug in the ear and continue to let them know that things need to be done, and they do. I mean, I think that's the thing, is I think people want to do the right work, but like you had mentioned before, there's limitations, right? You know, we're kids doctors, and so we have no limitations, right? We do anything for them, but the truth is yes, you know, there's only so much money, and trying to figure out where it goes. But I think it's you have to be relentless, right? Because systems can change, and they will, and they do, and I see it all the time, but it's not always the first go around. And it's just realizing again that little bit of effort, huge payback. And I know that it seems like 50% not coming, but that's still, I mean, that's a lot, you know, that's amazing. And having that clinic embedded, and I think that's something that, you know, has been in discussions for us too, but hasn't taken off, because it's always easier when it's yours, right? Because then you just know the people, you know, all of that, but not always realistic for everybody. But just again, trying to partner with your community and your officials, and not letting it go.
No, I think it's a good point. Wait, I don't like 50% actually showing up is, you know, that beats a lot of adult numbers, but also more importantly, the counterfactual is 0%. And so, you know, I think, yeah, I view that in many ways as a success for a new program to be able to get kids newly into treatment. One of the things it might also reflect, and I do want to ask you both about, is, um, you know, we know that in adult populations, many people will go in and out of treatment. And so there will be, and it's fluid. It's not like, very, very rarely do you see somebody in the adult world now who has never tried treatment before. And it's really about how do you restart that conversation? How do you do that brief motivational interview? What do we figure out what their needs are, and how do we help sort of get them back on a track towards recovery? I have to think it's a little bit different in that adolescent population, that you might be having a lot more first time conversations, first time treatment. And it's also, there's this added complexity of parents in the dynamic as well. And so how has sort of the, the bridge model and that sort of ED initiation based model, like got around those types of challenges?
Well, I think many of our patients were first timers. But as you alluded to in the adult world, we did have a number of patients who came back for repetitive visits, who had actually been through the cycle, had already been involved in MAT programs. My firm belief, and we looked at this, is that we have to address the mental health conditions or disorders that impact opioid use in general. So, for instance, we used a mental health screener, and of the patients we studied, 80% were positive for depression, 90% were positive for anxiety, and 10% came in with suicidal ideation. Those are extraordinarily high concerning numbers. And I think one thing that we're facing, as exists in the adult world, is if you don't address the underlying circumstances, conditions that impact opioid use, then you're essentially treating a use without looking at the etiology or basis for the problem. And I think that's our big, big challenge. And as I'm sure many of you listening to this understand, mental health services for kids, especially in a Medicaid population, are few and far between and rare, and that's a tragic story.
Yeah, it reminds me of a line we had before when we were talking about this on a prior episode, which was around this whole sort of comorbid issue and co-occurring illness issue, which is really simple. I loved this. The basic mantra was this, which was in somebody who's got, let's say, depression and OUD, you can't treat their depression effectively unless you treat their OUD, and you can't treat their OUD unless you treat their depression. What's unfortunate, I think, is too often in healthcare, we do a lot of splitting. So we say, well, okay, the depression is going to be treated by psychiatry, and the addiction is going to be treated by addiction medicine, and we somehow lose the forest of the trees, which is that you got to treat both. We got to figure out how teams can work together. Often it's actually a primary care model that can actually do both kind of things. And so, how do you avoid? I'm going to ask you this question, Rebecca. Like, how do you avoid that sort of that over siloing or splitting when we've got highly specialized medicine, but we want to sort of treat the patient, right?
It's very difficult, I'll tell you. And so I think it's, let me think. So, the one thing, just to sort of one point for the last question, just really quickly, is I think working on destigmatizing was very helpful for us, right? Because these are chronic illnesses, just like in talking to families, right? Because the family's like, why would I want to do this? And it's like, this is just like if your kid had asthma and they need QVAR, they need this medication. And so I think really working on destigmatizing, because then people also don't feel like they're failing when kids come back, right? Because it's, again, kids come in when the wind was really bad here. We had the fires. I'm sure you guys saw a lot of asthma exacerbations, right? And so I think that's part of it. And I think that you're right. It's in California, they've been doing some things where they're changing a little bit of the laws as far as mental health. Like before, when somebody was put on a psychiatric hold, you couldn't have a substance use disorder in order, technically you shouldn't. It happened sometimes, but they've actually changed the law now to include substance use disorders, because I think they realized it was fractioned out before, right? And it's not, they're all in our book, our DSM, right? They're all in there. And so they're trying to, they did that, but the problem is technically mental health inpatient units are not paid for somebody with just a substance use disorder, because again, that's where insurance separates it, right? And so I think it's going back to the systems and realizing that it shouldn't be fractioned, right? Even now, like if a child is on a medical admission and they come to the psychiatric unit, it's a separate admission because it's separate insurance, separate payer, and trying to get, I think it follows the money, right? I think if we could realize with the money that this is holistic care and it doesn't matter if it is asthma or eyes or diabetes or OUD or whatever, that we need to treat these patients. And so I think we've embraced some of them into our psychiatric world to try to help. I guess, again, most of these kids, profound anxiety, PTSD, major depression, ADHD, and really aggressively treating those while we're treating the substance use disorder is helpful. But not everybody has, like I said, the embedded team. And so, but it's I think a huge system shift that needs to happen in order to get these kids really what they need. But involving the family, of course, too, is challenging. And because it's in California, they actually had a law come out about a year ago that said children over 16 would actually be able to get buprenorphine without parental consent. I think it was embedded in a bill for kids who are unhoused, because I think a lot of children were showing up to emergency departments desperately needing this medication and they weren't able to do it. And I know that the California Bridge was big in helping this law get implemented. And as great as that is to start them on the medication when they're in the emergency department without their parents, how do you get them to the treatment without their parents? And so I think that's a thing that fortunately is in pediatrics, we work a lot with families, so we're used to that. But that's something that I think we could also, think about too in helping our colleagues in the emergency department is how to navigate those conversations with the family. Because again, sure, we could give it legally now to these kids, but how are they going to get the follow-up? And so getting the family or somebody, an adult, to help support them through the journey.
Thanks. Yeah, no, they're all good points. One last question for you both, which is not really a question at all, but it's something I offer all of our guests that come on the show is you're the experts. You know so much about this space. You've accomplished so much. And so I want to give you both the soapbox. If there's one thing that you want all of our listeners to sort of take away from this and know, or sort of change how they either practice or they lead in their organizations, what's that one thing? And so, Rebecca, you can go first.
I want to quote Nike and say, do it. I think that it seems like a behemoth, and I know we've talked a lot about a lot of challenges, but at the end of the day, the medicine is relatively simple, right? And fortunately, a lot of hospitals have already created protocols and there's already plans in place that I'm sure they would let you borrow, right? I know you could take ours if you wanted. And so I think just ripping off the Band-Aid and doing it, because I can't tell you, it feels also really good, right? I mean, at the end of the day, we do get that reward because you do see these kids who are starting to feel better, starting to feel hope. And I think that's what's so difficult is this is not a hopeless endeavor, right? We can help we are helping, it's not we are helping them. And so just, jump in, because again, though there's a lot of fear, there's science. There is a lot of science behind this. This is evidence-based. This is not something that this is not voodoo. And so I would say, be fearless, but you're backed with a lot of support too, and a lot of data.
Alan, what do you got?
I would echo what Rebecca says, and that's just understand this isn't just an adult problem. Adolescents are hurting. We live in society where stress, anxiety, depression, and the challenges that youth face are tremendous. It takes one person to be inspired to develop a program. And once that train starts down the track, it'll pick up passengers and additional people with interest, passion. And I would just encourage all your listeners to see this as a program that isn't optional, but is essential, and get on the bandwagon, start it off. And there's lots of people I found very willing to help and assist in the making of very effective and valuable program.
That's great. I'm going to simplify it from what I heard from you both. This is a real problem for kids. Just do it and you will save lives. And so thank you both for joining. It was wonderful having you on. Hope to have you on again in the future, and good luck with continuing to sort of spread these programs and help support kids around the country.
Thanks so much for having me.
Thank you so much for this opportunity.